Q&A function. You can put your questions there so that at the end we can have the panelists answer the question. If there's any other housekeeping, Dr. Agnes will say that before we start. Otherwise, we are ready to get going this time. Dr. Edith Apondi.
Thank you very much, Dr. Wamalwa. Dr. Irene, are you in? You can do yes. The welcoming. Thank you.
Okay. Thank you, Dr. Edith. I request not to put on my video, although I can put it for a minute because, okay, the host has stopped it. But I would like to welcome Edith. Edith is a pediatrician from Moi Teaching and Referral Hospital with a long-term experience working with adolescents, taking care of them, and also doing research with them. She will be representing our group, telling us about the Kenya HIV Adolescents Implementation Science Alliance, a new baby we are trying to birth. We've had a lot of encouraging research results. We've heard from the adolescents themselves, and we know that as the people who bear the largest burden, we are still struggling to make any dent in addressing the issues that affect the adolescent health. And as a team, we are coming together to address the know-how, the no-do gap, so that the great work that has been reported here by the researchers is translated. The work done within our context is translated to practice. So this is what KHISA is trying to address. And I'd like to invite Judy to, not Judy, Edith, to actually tell us about KHISA, what we are doing, and who we are. So welcome, Dr. Apondi. Thank you.
Thank you very much, Dr. Irene. I request for my slides to be shared. Just a minute. Thank you very much. So I'm going to make a presentation on Kenya Adolescent HIV Implementation Science Alliance. I make this presentation as the principal investigator, and we are a large team, and so I'll introduce the team as we go. So next slide, please. Early in about 2017 and 2018, we had an organization called AHISA, which is Adolescent HIV Implementation Science Alliance, a USA-based organization funded by Fogarty and NIH, invite a team from Kenya, among other countries, to several trainings on implementation science in 2017 and 2018. And so because of the several meetings that we got, the several trainings that we attended, we got to know each other as a team from Kenya. And we became close colleagues. And that is how we ended up having the discussion about having a Kenya Adolescent HIV Implementation Science Alliance. So KHISA basically is an alliance between stakeholders working in the field of adolescent HIV with one purpose of building capacity for implementation science in Kenya. We made the decision to make an alliance in 2019 after receiving a small seed grant from AHISA to allow us to have meetings and to get to know each other. So KHISA is a new organization, although it was formed in 2019. The initial membership was only formed of the members who got to know each other from the trainings in the US. And after we made the decision to create an alliance, we have been open to new memberships, and the membership is open to organizations and individuals. Next slide, please. So the vision of KHISA is to have 0 new HIV infections and 0 HIV-related deaths among adolescents and young adults in Kenya. And our mission is to build implementation science capacity among stakeholders working in the field of adolescent and young adult HIV in Kenya. Next slide, please. So we have these objectives. The first and the main one is to build capacity for implementation science among stakeholders who are in the field of adolescent and young adult HIV in Kenya. And our second objective is to create collaborations for grants, applications among stakeholders, and to support sharing of information among stakeholders. And the picture there is one of the meetings that we have had as initial members of KHISA. So we have Dr. Irene Inwani. I think some of the attendees know her. We have Dr. Kinuthia there. We have myself, we have Judy Washira, we have Cyrus Mugo, we have Salim Bakari, and we have Tabitha Kamau, who is our administrator. Next slide. And we have other members who were not in that meeting, including Professor Kawango. So the structure of KHISA, we hope to have a technical advisory committee. This is yet to be formed, but this is the vision, to have a technical advisory committee. And then we have the Secretariat. The Secretariat, I think there's a slide on that. And then we hope to have working committees and organizational members. Next slide. So our proposal for the Technical Advisory Committee, we are yet to approach these organizations formally. And so you'll excuse me if you are from the organization and you're surprised to see your organization here. But the hope is to be able to invite organizations to that lead the country in the field of adolescent HIV to be part of the Technical Advisory Committee. The organizations we have in mind include NASCOP, where we hope to have NASCOP, NAC, the MOH County Executive Committee Chair, and then participating institutional heads, and NACOSTI, and an adolescent and young adult representative, and the Ministry of Health Department of Adolescent and School Health. And the chair of KHISA, we hope will be the secretary of the Technical Advisory Committee. Next slide. So the secretariat that already exists includes the chair. The chair is Dr. Irene Inwani, who introduced me, and I am the co-chair, and we have Tabitha, who is the administrator. We are currently housed at MTRH, at the Adolescent Clinic in MTRH. Next slide. Our achievements so far, because this is a young organization, and initially our meetings were basically to get to know each other and to build our knowledge around implementation science. We are yet to do a lot more activities, but one of the activities that we've been able to start is to collaborate to have this symposium today. We have a secretariat. We have developed the key documents needed to get us going, including a strategic plan, a terms of reference, a work plan, and we have MOUs for engaging partners. We have been able to increase our membership from the initial members who were in the trainings after mapping out stakeholders in the country. We have started collaborative research as members of KHISA, and we have a systematic review ongoing on the research activities that are in the country around adolescent HIV. And we have an activity for next year aimed at starting implementation science capacity building in the country. And I'll talk about that in another slide. So next slide. Of course, we've had challenges since we started in 2019. COVID came just when we were gaining momentum, and it interfered with several activities, including physical meetings, and we had to rely a lot on virtual meetings. And of course, we all know the other ways that COVID interfered with many program activities. We have also had a lot of changes in the HIV implementation landscape in the country. For instance, we know of the many changes that have happened in terms of implementing partner coverage in regions. And so some of the partners we had mapped out for partnership, some are non-existent, and some have changed name, some have changed the areas that they're covering. And so some of that work will have to be reinitiated. We also have a membership, our key members are also people who have very many responsibilities. And so that there's a little bit of conflict, not conflict of interest, but generally people have a lot of other core responsibilities that do not, that interfere with their engagement with the KAHISA. But this has not been a very big issue because our activities are not that frequent. Next slide. So what is our main agenda for next year? So our main agenda for this year was to support the symposium that we are having now. Our main agenda for next year will be to initiate capacity building for implementation science in 5 HIV burden counties in Kenya. So this will be an online training and it will be a 5-day training. We have targeted 5 HIV burden counties, including Kisumu, Siaya, Migori, Nairobi, and Homa Bay. And we will train 4 to 5 members per county. We will use the KNH training platform that is also supporting this symposium to do this implementation science training next year. And we are very grateful for that. And then we have already sent out letters to these counties to invite to ask for nominations of trainees. And we have started receiving responses from some of the counties. After the training next year, we hope to support post-training implementation science activities, which we target to be mostly quality improvement-based activities in the field of adolescent and young adult HIV. And then after those activities, we hope to have another symposium where they will be able to present their outcomes and with continued membership of the trainees from the trainers. The trainers will be the same ones that KNH has used before in implementation science training. Next slide. So these are our contacts. We take this opportunity to invite new membership to KAHISA. The hope is that anybody with an interest in adolescent and in young adult HIV can become a member so that we can have a common forum for exchanging knowledge and also for collaborations towards research, among others. So these are our contacts, our email address, our website, as well as our phone number. Of course, we are a young organization and we hope to grow beyond this. That should be my last slide. Thank you very much for listening.
Thank you very much, Dr. Kapondi. Very exciting. And there are questions already. There's a question for you, which you will answer later. Now, Dr. Sarah Masuko has joined, and I'd like to welcome her and to invite her to give us the introduction, which she should actually have given, but she was not able to. Dr. Masuko from the Ministry of Health, and also a postdoc in implementation science at the University of Washington. Welcome, Dr. Masuko. Go ahead, you have 15 minutes.
Thank you so much, and thank you so much for your patience, even in adjusting the agenda. Sorry about that. So as Dr. Professor Omala has already said, my name is Dr. Sarah Masiuko. I work in the Ministry of Health. I'm also a postdoctoral scholar at the University of Washington, where I trained for both my master's and my PhD. And I'm really honored to be here with really my teachers, Professor Ndwati, Professor Amalwa, Dr. Inwani, and many others. So thank you for the invitation to this symposium. So I'm going to introduce you to implementation science briefly, and then if you have any questions, you can ask at the end. Okay, so I just want to acknowledge the International Pediatric HIV conference that just happened last week, and some of these slides are actually borrowed from that conference. And I want to acknowledge Dr. Anjuli Wagner, Dr. Irene Juguna, and Dr. Ariana Means, who helped in making the presentation. So some of how I'm going to go through this, I will use an adolescent example, and we will investigate really where is our gap between what we do and what we know and what we do. What is an implementation science question? What are the solutions that can overcome barriers? And what tools do we use to test these hypotheses? And how can frameworks be helpful at each step? So in summary, we introduce and we say that implementation science asks and answers the fundamental question really of how do we get what works to people with greater quality, speed, fidelity, efficiency, and relevant coverage. So really what is key is that you already know what works. And this is usually like a gap when you look at from discovery to translation of service for it to become policy and to become practice. The biggest gap usually is that it takes, actually research says that it takes about 17 years from getting a new intervention that has been discovered to actually getting into clinical practice. So the role of implementation science is actually to shorten that gap from what we know works, that has been tested, it works, to actually getting it to people with greater quality, speed, fidelity, efficiency, and relevant coverage. So that's what we'll be talking about today. So I will use this story about Dr. Imani, and it's a program manager who is working in a region. And the program manager, Dr. Imani, has heard that there is an increase in teenage pregnancies in her region. So she's asking herself questions. Okay, so what do I need to do? How do I need to change this? And we'll use an implementation science lens to answer this question. So the first question that you do ask in implementation science and in any research is really, where is the gap between what we know and do? And in implementation science especially is what we know. So what do we know that works? And really why are we not doing it? Or if we are doing it, why are we not doing it well? So for example, in this region, there are X number of unintended pregnancies among adolescent girls. We can say 40% among adolescent girls. And we want to change this to 0% of pregnancies. But one of the things that affects how we talk about, what we know and what we do is really a lack of awareness on sexual and reproductive health. So we talk about this gap, some of the challenges that we do have, and then how do we address them? So we talk about this as challenges. So is there an issue with the training? So are these girls receiving the training or not? Is there capacity building around that? Or is there a problem with information from peers? And is there something which is a misinformation, or there's some peer pressure or something else? Or is it that the tools for them to prevent pregnancy are not there, so they do not have access to contraceptives or to even information about abstinence or condom use or other ways to prevent pregnancies? So you'll think about you can use this framework for any question that you do have, and answer, okay, so what are the challenges? And then you check, what are the most important challenges? So maybe training is an important challenge, followed by information, and then the tools. And then you say, okay, all these things contribute to a lack of awareness on sexual and reproductive health. And here, when we talk about challenges, we just don't talk about challenges, we talk about barriers, we talk about implementation determinants, drivers, and other words. Those are some of the words that we would use in implementation science. So what is Dr. Imani's implementation science question? So the question here would be, what strategies can improve the efficiency, timeliness, and fidelity to SRH capacity building? So we use a framework, they're common in implementation science are frameworks that we use to look at what all these things. So this is a framework by Proctor and Ola, and it's an implementation outcomes framework. So it defines implementation outcomes that are different from service outcomes you see on the right and client outcomes. So commonly we talk about client outcomes. How did it improve teenage pregnancies, all those, and service outcomes, how do we make this efficient? But implementation outcomes actually look at a bridge before that between our interventions and our actual clinical outcomes. So we start with an intervention strategy. We say we have an evidence-based intervention, maybe a training that has been used, a life skill training for adolescents. And then we look at what strategies can we use to implement this. So we know what works, and then how do we deliver what works? And that's what we call an implementation strategy. So when we're defining that, you think about a systems environment, what is surrounding these adolescents, what is surrounding the training, what do we need to be able to put, what organizational changes do we need to make, is there supervision that is needed, and all that. So look at implementation strategies that you can be able to use, and then you measure outcomes. And in implementation science, we go beyond clinical outcomes, service outcomes, and client outcomes to look at implementation outcomes as well. We talk about feasibility, we talk about fidelity, we talk about penetration, acceptability, sustainability, uptake, and costs, which are very important in implementation science. Together with these others, give you a really good idea of what is happening. And then next, we talk about what solutions or strategies can overcome this barrier. So we talked about a challenge of lack of capacity building. So what solutions can overcome these barriers? And the perfect fit of solutions. In implementation science, we talk about, it's not that we are doing things without rigor. It's important that everything is done without rigor, and it's not just research, it goes beyond research. So a lot of times there's a problem because you can choose a solution, but it's a poor fit with an infrastructure availability. So maybe you want to have implants for adolescents, but really there's no infrastructure to deliver implants, or technology to be able to give implants to the adolescents. Or maybe there's a distinct, it's not very different from what is current practice. So whatever you do has to be a good fit and experience with an existing practice, and there has to be that enthusiasm and for expansion. So you have to be able to have everybody's buy-in, the infrastructure and the practice and everything coming together to make sure that it's a good fit to answer that question. So some of the gap between what we know and what we do, how can we be able to fill that gap? Data, information is what is most important. So you can be able to hold stakeholder engagement. So Dr. Imani would call, the stakeholders and ask them what's happening. What do you think are the challenges? They would call parents and caregivers and other people, peers, and talk to them, and even the adolescents themselves, and say, okay, so what's the problem? They would also talk about routine program data, look at the surveys, like there was a survey in 2019 that showed, a high increase of about 40% of unintended pregnancies. Among those who are taking unintended pregnancies, a lot of them actually are not using family planning, things like that. So you would use those reports. And then experience of implementers, people who have been implementing adolescent programs. They have the information and they know what works, and they also know why it's not being done, so they can be able to bridge the gap. So seek data that is practical and specific enough. So what is an implementation science question? We talked about our strategies. So we talk about, has the intervention or practice of interest shown efficacy? So in implementation science, something has already to have been proven for you to actually investigate it. So you talk about, that's the first path. You talk about, is it yes, is it no? If it's no, then you talk about an efficacy research that you'd want to design for implementation. If it has already been shown to be effective, then yes. There are three pathways, you can think about. Has the intervention or practice shown effectiveness? So efficiency is in a control setting. Effectiveness is in a real world setting. So in now you have a trial which you did in a control setting, and now you're coming to implement it and roll it out in Kisumu County. So will it work? So you check then if does it show effectiveness in Kisumu, then it's an effectiveness research. If it's no or it's partial, then you might want to look at implementation outcomes together with its effectiveness in what we call a hybrid, where you are looking at both effectiveness and implementation. So the design of your study will be different. And then if it's yes, then you look at a mixed method study, you design implementation strategies, and then you test that implementation strategies. So the difference between other research, usually you test the intervention in visual research. In implementation science, we test implementation strategies. So that's where lies our implementation science question around implementation strategies. So what strategies can overcome the barriers? You need to brainstorm, you need to consult, you need to look at the literature, and in theory, what is happening. And there's a resource there that we've given from the University of Washington, the IMC Implementation Science, UW.org. You can be able to look at that, and it can explain to you how to define strategies, how to define a question, how to use a framework, and the rest. So what tools do we use to test these hypotheses? We want to test hypotheses around training. So you'd use either traditional or non-traditional study design, and we'll not go into that now. You can use an RCT or a quasi-experimental study design where you do not randomize participants, which is common in implementation science. You can use a survey, you can use interviews, you can use program data, you can use observational data. But there are important specific measures that are important for implementation science studies, looking at acceptability, feasibility, appropriateness, and others. So the TPIs, the skills you bring from other research disciplines, are directly applicable to testing implementation related hypotheses. So you do not work alone, you work with people who are also involved in mainstream research. And you can learn a little bit around testing hypotheses as well. And then I'm just about to finish is that how can frameworks be helpful at each step? In implementation science, we have so many frameworks, and they're important because they help you first frame your study question. They help you to select your implementation strategy based on what is your question. Then you can be able to select a strategy to use. And there are strategies that have been defined and listed as and categorized as important strategies for implementation. And you can choose from the website that we've given. There's a guide of implementation in different contexts. So you can be able to guide implementation in different contexts. You can also develop research tools and guide analysis as well. So when you're, for example, in qualitative work, then when you're working, there's a common framework that we talk about, which is a consolidated framework for implementation research. And we use this, it's called the CIFA framework, and very useful for mapping barriers and facilitators. So it can guide your analysis as you look at your transcripts for qualitative research. So there's over 60 implementation science frameworks. Actually, there are more than 60, very many more. But they are categorized into three. One which looks at processes, one which identifies factors, that's process frameworks. And then there are determinant frameworks where you look at factors that influence implementation. And then finally, there are evaluation frameworks that you do look at. So frameworks are used to systematically approach a question, and inference is deepened by linking, contrasting, and comparing to existing scientific knowledge. So in summary, some of the methods that we do use in implementation science, and in those like the trainings that I'm sure Dr. Imani and Dr. Pondi will be conducting, are implementation impact evaluations and study designs to measure effectiveness. You'll use operational research as a contributing discipline. There's surveillance, economic analysis, and cost effectiveness analysis. Stakeholder analysis, which is really key, and policy research. We also work with qualitative health system research, quality improvement, social marketing, and dissemination research. So going forward in your research, approach an adolescent challenge in your practice in this way. Ask yourself, where is our gap between what we do and what we know? What is our implementation science question? What solution or strategy can overcome the barrier? What tool do we use to test this hypothesis? And how can frameworks be helpful at each stage? So I want to acknowledge the organizers of this workshop. Thank you for inviting me. I want to acknowledge Dr. Anjuli Wagner, the IFASA who did, I got some of the slides from, and then the University of Washington Implementation Science Program, and Dr. Irene Njuguna and Ariana Means. So thank you very much.
Thank you very much, Dr. Masuko. Very exciting, really laying a good background. People are already asking how they can get the training. I'd like to propose we continue and still use the Q&A for your questions, which shall be addressed at the end. We'd like to move on to Dr. Keegan Korir. Keegan, you're on, and you're talking to us this afternoon about the multi-sectorial coordination in prevention and response to teenage pregnancy. Kindly introduce yourself and proceed. The floor is yours. You have 15 minutes. Thank you.
Thank you very much, Dr. Omalwa. So my name is Keegan Korir. I'm the program specialist for adolescents and youth at the United Nations Population Fund, UNFPA in Kenya. And it's a pleasure to really be able to engage with colleagues and practitioners around this critical topic of teenage pregnancy, which has really been in the circles in the country for quite a long period of time. And so specifically, I'm going to be sharing more about the importance of a whole system approach, looking at the various actors and the contribution that they have within, in terms of responding and preventing teenage pregnancy in Kenya. And so just very quickly, just to give the context, is that we've had a long, long spells of high prevalence of teenage pregnancy in Kenya, where we talk about 1 in every 5 teenage girls being having either given birth or, being mothers already. And this rate has remained pretty much unchanged since 2008. We have counties which are more disproportionately affected than others. Looking at Narok County, for example, at 40%, and counties like Kirinyaga at 6%. But then again, specifically looking at some of the service statistics from the Kenya Health Information System, we've been operating literally at a range of about 300,000, even going by last year, where we had around 318,000 pregnancies being recorded in the facilities. And so, of course, that tells us that, yes, while the numbers are high, this is just a fraction, because not necessarily everyone goes to the facilities for the services. Now, just reflecting on some of the drivers of teenage pregnancy, and sexual violence, of course, is one critical factor. You have issues of lack of formal education, where almost 3 times the girls who don't have secondary education and above are likely to get pregnant compared to those ones who have primary education and below. Another critical factor, of course, looking at access to sexual and reproductive health information and services. And this is attributed to many factors, looking at limitations in our education curriculum, parental guidance and engagement, issues around the responsiveness of healthcare services, the healthcare system, to the unique needs of adolescents. Sexual debut is a critical factor. Of course, that is really directly linked to why we have these pregnancies. And this is understanding adolescence, the period of vulnerability, decision making being a bit poor, and peer pressure, and looking at the data of 2014, about half of boys, 57% of boys, 47% of girls had initiated sexual activity by the age of 18. That is looking at the cohort between 20 and 24 years. Now, poverty, of course, is one of the root causes, linked to access to education and many other factors, including the environment within which the adolescents are living. And of course, harmful practices, looking at child marriages, and of course, the fact that it predisposes the adolescents, of course, to adolescent pregnancies for that matter. Now, if you look at, the space within which then the adolescent is operating, the social, ecological context, and that is why we actually talking about the need for a sectoral response. And going by this framework, you have the adolescents at the very, very lower base, And closely related to that is the context of the parent, the household, and the interaction that they have with their peers. And then a bit outside, there is the institutional arrangements where you have the school, the interaction with the teachers and what have you. And then again, as you go outer to the layer, you find that we have the community where these adolescents live. You have the community leaders, you have the religious leaders. And then outside the outer part of the circle, then you find the policies, the policies that really guide various factors, including the provision of services for adolescents, the protective environment in terms of the laws around gender-based violence, Sexual Offences Act, and what have you. And of course, then the effect of the political class and the decisions that they make. All these really influence be it the behavior and also the context within which the adolescents live. And so looking at the critical actors that then are going to inform the whole issue of multi-sectoral response, you have the adolescents at the center, but then you have all these actors who have a critical role to play. You have the parent, you have the law enforcement agencies, the judiciary, the child and social protection actors, of course, finance and planning, the whole, the architecture of the country in terms of really financing the healthcare system, the education system, as it were, the health sector, the education sector, and most importantly, the young people themselves, because we don't design programs really without the inputs of the people who are supposed to benefit from the same. So all these actors really are critical when it comes to addressing the issue of teenage pregnancy, because adolescents live in a particular context, which is shaped or are shaped by these factors that we are looking at. So I want to take this opportunity to just look at the case of the multi-sector response in the United Kingdom. And this is one of the most touted countries in terms of having had a high level of teenage pregnancy that was halved in a period of about 10 years. And so, looking at the data, around 1999, it had one of the highest levels of teenage pregnancy in Western Europe. And, attributed to that also is the issue of unmarried teenage mothers, which was highest in the world. And so they came up with a 10-year multi-sectoral strategy that was largely at the national level, regional level, and local level. Just that the way we have our system of governance, the national level, the counties, and perhaps maybe previously the regional level. And so this particular strategy was interesting in that it combined around 4 critical thematic areas. One was the joint action between the national and local government. Secondly is the focus on improving prevention for girls and boys through improved sexuality and relationship education and access to services, particularly contraception. The third pillar was looking at a national communication campaign to reach the young people and the parents and caregivers. And examples of just some of the campaigns were, are you thinking about it? That's basically in reference to sex. And then of course, time to talk, which was focusing on the parents. And then lastly was looking at, the coordinated support for young parents. Of course, I'm sure most of us have interacted with the fact that a pregnancy for an adolescent without proper support is likely going to result in a repeat pregnancy. And so that was a very critical intervention to look at those first-time young mothers, the adolescent mothers, and making sure that we don't have incidences of repeat pregnancy. So then again, looking at the approaches that were used, the section and relationship education, youth friendliness of services, targeted prevention to the most at risk adolescents, programs targeting parents around parent-adolescent communication, use of data to track progress. Another critical pillar, of course, was the issue of dedicated support for teenage parents, access to services, and what have you. So really, it was a broad spectrum, but at the center, which was critical, was the leadership role of the government in changing the narrative. So looking at some of the salient features really of this strategy is that it was multi-sectoral, and by that it involved a wide spectrum of stakeholders adopting a 360 degrees approach, looking at the young people and the role of the other actors that we live within the context of young people in all this. And then, of course, again, the government coordination role at the national and local level. And so, for example, they had a specific teenage pregnancy unit, initially headed by the Ministry of Health, later on by the Ministry responsible for Children Affairs. It had a diverse membership, including CSOs, and also importantly, an intergovernmental coordination mechanism that then ensured that the different sectors and ministries were responded. And then, of course, that critical area was having an advisory group that was independent to track progress in terms of achieving reduction in teenage pregnancy. And so also critically is the involvement of boys and men in this conversation. And what I just want to further emphasize was sustained government funding over the course of 10 years. So those are some of the critical pillars that really ensure that this multi-sectoral response mechanism within the UK was functional. So as a result, there was a 51% reduction in teenage pregnancies over a period of 15 years, 10 years, but the research was done in 2014, then being able to look at this, and really it had halved for that matter. In Kenya currently, we have one county which is really trying to take this route. That is Migori County. They came up with a multi-sectoral strategy, 2018-2022, and going by what has been coming up, of course, is that there's really been a lot of successes going forward, and we anticipate to get more results by the end of the strategy. And then, so lastly, just by mentioning that as a country, we have a target of ending teenage pregnancies by 2030, going by the IPD 25 commitment. And so really, it's a conversation that we must have. We must be able to pull our efforts together, work together multi-sectorally to be able to achieve this. So thank you very much, and over to you.
Thank you so much. Very important subject. There'll be a discussion on this. We'll move on again in the interest of time. Dr. Cyrus Mugo. Dr. Mugo is going to talk to us about transitioning adolescents living with HIV to independent care in the attached cohort. Mugo is from KNH and University of Washington. Please go ahead.
Thank you, Prof. I hope you're seeing the correct display.
Yes, we can see it.
Okay, great. So thank you. So yeah, today we'll discuss a good example of an implementation science study, what we are calling the transitioning of adolescents living with HIV to independent care, the attached study. And this is work that is a collaborative effort between researchers at the University of Nairobi, Kenyatta National Hospital, the University of Washington, and the Ministry of Health. And I'm very honored today to be presenting this. So in the next few minutes, we'll be sharing the reason we need to focus on youth living with HIV, highlight gaps in care, specifically around disclosure of HIV status and transition to independent care, and then describe the attached study, share some of the preliminary results, and of the cluster randomized trial that we did. And then we can summarize the next steps. So over the past 20 years, we have seen a dramatic reduction in new HIV infections globally. And that's thanks to the very successful work in the PMTCT, cascades, especially, in Eastern and Southern Africa. We now have widely available effective HIV treatment, and over the last 15 years, we have seen children put on this medication surviving childhood, what we now call pediatric HIV. HIV incidence, among the youth, adolescents and youth, is still high, and this has resulted in us having a large number of children living with HIV now aging into adolescents and youth. Of note, we have these 15 countries, painted dark, majority in our region, Sub-Saharan Africa, that account for 75% of adolescents living with HIV. So in these countries, there are major challenges in HIV care for adolescents and youth. This includes differential on all age bands, defining the groups. And this means that research is affected because you are not able to get disaggregated data. We also have a lack of models for youth-friendly services and protocols around how to transition adolescents living with HIV and basically most chronic illness to adult care and then retain them in care. So many of these gaps are now being addressed either in research or in policy. So our work focuses on the transition from the adolescent to adult care. So, as a practitioner, whether you're doing clinical work or as an epidemiologist, public health practitioner, so sometimes you look at the numbers and it's easy for you to focus on them and dissect the numbers and think about the big picture. But it's important that we remind ourselves often that the journeys that these children take is often very, very difficult. And this is something that was said by one of the caregivers that we interviewed. The adolescent stage is something that everyone goes through. So as a parent, I urge everyone to understand that stage. It's the smallest stage in life and it's the hardest stage in life. And so just putting that in context. So where do we start? The first and the prerequisite step to transition to independent care is to tell adolescents living with HIV that they actually do have HIV. So the process of them knowing that they have HIV is the first step to thinking about them self-managing. So telling an adolescent that they have HIV is not easy. And this is something that healthcare workers have told us, parents have told us. And you can see this, 3 quotes, they're just telling us that it's not a walk in the park. Healthcare workers find it difficult. And what they want to do is really support the caregivers to start this process early on before the child becomes an adolescent. And then there are studies that actually show that if you wait too long, then you get negative outcomes. So the work done, there's some work done, that was done by University of Washington researchers who are also working here in Kenya and including this study. Researchers like Gabrielle O'Malley, Christine Bimasofi, who are part of this attached study. So they did this work in Namibia where they identified gaps and developed a tool to support disclosure. So these pictures are actually from their cartoon booklet that they assessed there. And it uses metaphors to describe the battle of infection fought by body soldiers. So they're calling body soldiers against a bad guy, and explain why children take medicine. So the booklet progresses across 5 chapters, helping children understand the immune system, what HIV does to the immune system, how the medicines work, and the importance of taking medicines every day. And in the last chapter names HIV. So the child gets to learn or to know that what we're dealing with is HIV, and this is the bad guy. So this tool was acceptable to healthcare workers, caregivers. The assessments basically were very, very positive in a very rigorous evaluation that they did. And it did improve disclosure experiences for adolescents and confidence for the caregivers and healthcare workers in disclosing too. So also talking about, questions about viral suppression. So this is one of the tools that in Africa has a very good evidence base that it works. Unfortunately, it's not widely used across many countries. So we have to think about how to, as Sarah said, get good evidence applying to many people as possible. So once HIV disclosure is done, the next step is to help adolescents gain knowledge and skills they need to dependently manage their care. So tools for this are largely lacking. You look at the literature, you have very few tools that help you do that. It's important to note that many HIV clinics in sub-Saharan Africa are not special age group clinics. So there is this general training, and you're thrown as the healthcare, well, not thrown, but you're asked to provide services to anyone who needs them. And so there's need for us to highlight the need for tailored services. So there are frameworks. What you're seeing now are some tools out there. This is the US-based, what they call the GOT transition tool, and it helps clinics systematically structure individual transition plans and examples of care plans from chronic care literature. USAID also developed a transition toolkit that is now being used in some although as stated earlier, they've not been implemented widely, largely because they're seen as cumbersome, and this is feedback that we got from frontline workers. So with these gaps in mind, this is back in 2017, we thought of now attach. And it came with 3 broad aims. One was describing existing disclosure and transition services in Kenya, developing a transition tool with stakeholder involvement, and we'll mention that how that went, and incorporate the validated Namibia disclosure booklet. And with this, we developed the adolescent package, a transition package, and then of course test this package in a cluster randomized trial. So we surveyed, as our first step, 102 clinics in Kenya across, you can see the little dots across the country, and identified that many clinics had specific clinic days of the week dedicated to adolescent care. However, definitions of transition were heterogeneous. There was not one definition we could actually pin as the one, and they were largely no tools to guide the process or track individual adolescents' progress. We interviewed caregivers, adolescents, and healthcare workers, and most prominently, the healthcare workers expressed a desperate need for disclosure tools. For transition, they talked about a tool to help with adulting, what they call adulting business. And this is guidance tools to assess and track individual transition progress. And they warned us that cumbersome tools, you develop cumbersome tools, they will not be implemented. So we took this information to an adolescent transition workshop. That was back in November 2018. You can see some of the participants here, including stakeholders from the Ministry of Health, the HIV care partners, mental health experts, we have pediatricians, adult physicians, so the ground healthcare workers, some adolescents themselves. And the goal for the meeting was to develop a framework for an adolescent transition tool that could be used in a program setting across many areas in the country. So from the workshop, we defined a potential transition framework that included specific transition milestones, readiness assessment, pre-transfer communication where applicable, and definitions for successful. Sorry. So we also identified transition milestones, included first, the disclosure of HIV status, then knowledge and skills to independently manage care. The attached team then worked with smaller groups to develop the intervention package, which we now call the Adolescent Transition Package. The intervention consisted of the Namibia disclosure booklet. You can see why I take my medicines, and a transition booklet called the Taking Charge. And we also had a readiness assessment tool and also a tracking tool. As I made in the previous slides, this one of the things that we could reflect upon is where we started. We started with growing up, thinking of the name to give the Taking Charge booklet. We thought growing up would be a great name. And we went with it until one of the youth members told us that adolescents don't like being told to grow up. So we had to think of a name that adolescents, would identify with, and that seemed to be something very familiar. That Taking Charge seemed something that they would like. So we went with Taking Charge booklet. So these booklets were translated in 3 commonly used languages in Kenya. So we had minor changes recommended at the transition workshop for the disclosure booklet to fit in our setting. That was the Namibia version. And these were changes, for example, in color used for soldiers. I think we had different colors for the soldiers. And I think in the context of Namibia, which was found not to be very similar to what we have here, and some few changes in the wording. So the adolescent transition intervention was composed of the structure, transitional guide, and the individual adolescent tracking tools that supported the adolescents gain knowledge and skills in 4 key areas. That was the HIV literacy, self-management, communication, and support. The text includes questions for discussion, notes, and punchlines, and many of these were actually suggested by other adolescents. Things like, later than ever, problem solved, is a problem halved, and some of those nice, punchlines that only an adolescent could probably give you. So this imagery of an adult handling a key to a youth, and the handing over a key to a youth is what is at the back of the book. That really highlights the vision that we had at the workshop. Basically, adults saying, take it. So the guide was presented in the form of a booklet or a flip chart, designed to be delivered at the scheduled visits, clinic visits, so by the healthcare workers. And this is an important aspect of the study, that the healthcare workers themselves delivered the intervention. And the study team provided training and supported continuous quality improvement. So we did some CQI cycles, largely aimed at increasing uptake of the booklet in the first 6 months. So we tested the ATP in a hybrid cluster randomized trial that includes effectiveness outcomes and implementation outcomes, youth age 15 to 24, our recipients. These were the youth who knew the HIV status. And those younger or who did not know the HIV status first went through the disclosure process. So we randomized 20 clinics to the package or to the control group. The primary outcome was overall transition readiness, assessed using a 17-item score developed to align with the 4 key areas. Secondary outcomes were viral suppression, retention in care, and we also had the disclosure outcomes. So these are the results. Overall, the study enrolled over 1,000 youth, median age was 21, majority female, and about a third were actually from the PMTCT clinics. And had known the HIV status in just the last year, 2 years. Baseline viral suppression was about 83%. Comparing intervention and control sites, the intervention site participants were older, more enrolled in PMTCT clinics, and more recently learned their HIV status. The baseline transition readiness scores were high in the intervention site, something that we controlled for in the analysis. At 12 months, transition readiness improved in both arms, and may be expected with increasing time. The adolescents had a year of growth in clinics, but there was a significantly greater change in the intervention arm, even after adjusting for the baseline readiness scores. So similarly, we found significantly higher scores in the HIV literacy, self-management and communication domains independently in the intervention sites compared to control sites. Which did not change after we adjusted for multiple testing. So for our secondary outcomes, retention and viral suppression were pretty high in the cohort, over 90% at 12 months, with no intervention effect observed. So in summary, this ATP significantly improved transition readiness, increased HIV literacy, self-management, communication support at 12 months. Importantly, it was administered by clinic healthcare worker and not research staff, talking about sustainability, and demonstrated effectiveness in integrated context. So easy to think of it in a wider programmatic use. Post-intervention, qualitative work suggests potential for sustainability, like, what this quote from a healthcare worker, reflecting on the ATP said, we have had, that youth have come back to the clinic between visits to review chapters in the booklet. Some have asked for it too, they want the book. And as recent as the last week, 4 months, after the study ended, we provided additional, counseling using the book. As with other studies, the intervention administration over the COVID period was switched to mobile for a few months, since the face-to-face interactions were not suitable at that time. And we got some supplemental funding to study this aspect of the study, and those results have been presented in other forums. So we were basically underpowered to study disclosure. There were very few of those whom we recruited in the age bracket that were allowed that had not been disclosed to. In the next few weeks, we will continue to review implementation outcome data that is still to come out. We are planning new grants aligned to the study, including thinking about how we can use these tools to tackle stigma. We have also obtained funding to study the school environment. Dr. Irene Njuguna is leading a study on looking at the school environment and also thinking about adolescent mortality and viral load monitoring. Many thanks, study participants and our great healthcare workers in the facilities. The support we received from all research persons in the University of Washington, in Nairobi and KNH, also Ministry of Health. Many thanks. Thank you.
Very much, Dr. Mugo. Very exciting and very clear presentation. Transition. We just have a few more presentations, 3 to be very specific, and I'd like to welcome Dr. Judy Wachira. Judy will present on implementation of peer navigation to increase uptake and utilization of HIV services among street youth.
Good afternoon, everybody. This is Paula Breitstein, and I'll actually be speaking on behalf of the Kenya team that includes Dr. Apondi, Professor Ayuku, and Dr. Wachira, who I think are all with us today. Thanks very much for the invitation to present this. So as one of the earlier speakers talked about, the real challenge now that we have so many effective HIV interventions is bridging that no-do gap. So peer navigation is something that's been used a lot in the field of HIV, and street-involved children have been really, really under-engaged in HIV services, particularly in sub-Saharan Africa. So I'm sure all of you know that there are a lot of street-involved children and youth, some of them on the streets day and night, and some of them on the streets just during the day. And they're in the cities all over, even smaller towns all over Kenya. And surprisingly, the public health literature has really mostly focused on their substance use, their health in general, and the causes of street involvement. And each of these 3 references actually to a systematic review and meta-analysis of each of those 3 issues. Street youth are a very highly vulnerable and very marginalized population of young people, and it's very, very difficult to know how to engage them. In fact, until 2015, there were no estimates of even HIV prevalence among street youth in sub-Saharan Africa, whereas in Western Europe and North America, we have a lot of estimates about HIV incidence and mortality and so on, largely because of the epidemic they're driven by injection drug use. So street youth, at least in Kenya, are a highly complex population. First of all, there's the survival imperative. Their basic needs are fundamental and drive most aspects of their life. In that vein, they use a lot of substances, predominantly inhalation of volatile solvents, i.e. shoe glue, sometimes gasoline, some alcohol. But what we've discovered is that substance use is often a part of the initiation process into the streets, and is part of how street youth create a sense of comradeship with other folks on the street. It's kind of like a community development, like bonding type situation. There are also really high rates of violence, physical, emotional, and sexual. And we've documented this in a number of papers. And again, some of it is related to initiation practices, of children and youth onto the street. And some of it goes back to the survival imperative. So, for example, survival sex, exchanging sex for food or, shelter or protection or something like that. As a result of most of these issues and whatever they experienced before they ended up profound mental health challenges, including addiction, depression, post-traumatic stress. And they also have a lot of challenges around sexual and reproductive health. So we've documented both a high prevalence and a high incidence of HIV and sexually transmitted infections. So this is some recent data looking at, on the left panel, HIV incidence, and on the right panel, mortality, comparing street youth in yellow to orphaned youth, children and youth, basically living in charitable children's institutions, so orphanages and rescue centers in Kenya, and orphans living in family-based settings. And as you can see, even compared to orphaned populations in either of these other two home environments, street youth have actually 17 times the risk of acquiring HIV. And this is adjusted for, age and sex and length of time in that care environment and so on. And they have a 5.5 times higher rate of mortality compared to orphans living in these other two environments. And this is really important because it means that we're really overlooking an extremely important population of adolescents and youth living with HIV and at high risk of HIV. And as a result of all of this, it's resulting in too many preventable and premature deaths from primarily actually HIV. So we systematically documented causes of death among street-connected young people in Eldoret over about a 7-year period. And HIV accounted for the majority of deaths, particularly among women, all right, at 59%. Whereas although it was also very high among males at 26%, you can see here that assault actually accounted for a larger percent of causes of death in this population. But just to come back to the point that HIV is a really big deal for this group. Now, because they have such complex and profound challenges facing them, there are really no simple solutions, okay? So we took the approach of at least starting with trying to prevent them from acquiring HIV and to prevent them from dying from it if they were infected with it. And so to that end, we started with a pilot project of peer navigators, okay? Based on a community-based peer navigation program in Canada, where I'm from originally. And we hired 2 former street youth as peer navigators, mixed gender, mixed HIV serostatus, and they were literate and numerate to about a grade 5-6 level. And the goal of their work was really to link street youth to existing services, particularly HIV testing, treatment, and related services like reproductive health, for example. We focused in this pilot on youth less than 25, and we evaluated this pilot over the course of nearly 3 years. And we found that of the 781 children and youth we were following, 63 were HIV positive, including 4.6% of males and 18.4% of females. So in general, the Peer Navigator project resulted in a very high percent of people of street youth knowing their HIV status. This is of the 781, so almost 90%. A very high percent of people, not quite 90%, but over 80% of those HIV positive initiating antiretrovirals, and a smaller percent of those who have initiated ART having viral load suppression, okay? So clearly peer navigators are not a panacea, but at least they start engaging the population and get them into the health services, okay? So, clearly more supports are needed to support adherence. And we have some other work on that I'm not going to present today. So the second stage of this peer navigation project was really funded. Well, it's been funded by the Canadian Institutes of Health Research through a team grant called Component 2 HIV Implementation Science. And the name of the study is Adapting and Scaling Up Peer Navigators to Increase Uptake of HIV Prevention, Testing, and Treatment among Street-Involved and Homeless Youth in Canada and Kenya. So we actually have 3 sites in Canada, in London, Ontario, Montreal, Quebec, and Toronto, Ontario, and 3 sites in Kenya. So we've expanded in Eldoret. We've added Huruma, which is one of the settlements on the outskirts of Eldoret, and Kitale, which is in Trans Nzoia County. So in all of the sites, the primary population of focus are homeless and underhoused youth under 30 years of age. And in Montreal and Toronto, the focus is primarily on lesbian, gay, bisexual, queer, transgender, and two-spirited homeless youth. Okay, two-spirited folks are Indigenous people in North America who are not heterosexual. Okay. And the project runs for 5 years. So the first part of this scale up was actually in assessing the acceptability and conducting a pretty rigorous adaptation of the intervention in each of the sites. And so as part of that, we documented barriers and facilitators of accessing HIV services for street youth, the acceptability of the peer navigator model, and adaptations needed of the intervention in each site according to street youth, healthcare providers, and community stakeholders. So through this phase, we engaged 195 participants in all of the sites, including 64 street-involved youth, 42 healthcare providers, and 97 other stakeholders, mostly from the community. And now we're well into the implementation and scale up. But just to sort of give you a brief picture of the barriers and facilitators to accessing HIV services, much like Dr. presented one or two presentations ago, you really have to look at uptake and utilization of health services in the social ecological context in which these individuals live. So of course, there's like a long list of barriers, okay? Starting from intersectional stigma and discrimination against them because they're homeless, against them because they're poor, misogyny against women, LGBTQ folks get it. In addition, issues around adolescent sexuality and reproductive health come in, and there's a lot of intersectional stigma and discrimination around that. A lack of access to basic needs, lack of legal documentation. Many of them, even though they're 18 and above, don't have their national ID. They have no money to pay for health services. And certainly in a place like Eldoret, there's really limited community-based supports for this population. Okay, and then there are a variety of barriers also at the institutional level, including a lack of inclusive education and training among healthcare providers in how to deal with this population. And it takes a special kind of person to be able to be welcoming and engage respectfully with people who are high, who are dirty, who might scare you, this kind of thing. There's not a lot of HIV educational outreach in the community, certainly not to this population, and a lot of ineffective communication between service providers and the street youth population. And then, of course, there's a lot of interpersonal barriers, like, a lot of lack of trust and associated fears, low perception of need for healthcare, and a lack of self-esteem. But what we did identify was that among the facilitators, peer navigation through systems navigation support, the peer relationships, personal relationships, the need for increased outreach and, making care more available and accessible, all of these things fit really, really nicely under the peer navigation model. So as of the end of October, in Kenya, we've enrolled 538 street youth, including 307 males and 231 females, and there have been 246 follow-up encounters so far. About a quarter of them sleep on the street or in a park or public place. 30% or so share a shelter with other street youth. This is typically a very temporary thing, and it's like one room and many of them get in there together. 29% share a rented house or apartment, and 13% are living in a group home. So 68% of them had ever been previously tested for HIV, of whom 15% were HIV positive, of whom 98% were in care, which was very good. And the majority, 76% of those who were willing to test, who had either previously tested negative or didn't know their HIV status, accepted testing, of whom 1% were positive. And we also managed to engage 29 currently pregnant females so far, and trying to get more and more of them basically into ANC, because you can see this is a bit low at 76%. We've had more challenges, interestingly, with the implementation of this intervention in Canada. So in Toronto, we had a peer navigator hired in February, which was right in the middle of winter, okay, in Toronto, which makes any kind of outreach really hard to start with. And also it happened at the same time as COVID hit, which meant that they couldn't do their normal outreach, say in community-based organizations or at the clinics, because in Canada, restrictions and lockdowns and so on meant that you were basically not allowed to leave your house except to get groceries. So, you know, eventually with time, it worked quite well, but no participants were enrolled. So the peer navigator ended up like, you know, engaging with people and referring them and following them up and so on. But she wasn't able to actually enroll any participants. And this was because there's a long history in Canada among Indigenous people, for example, and LGBTQ people, of you know, research fatigue and suspicion of research, and so people were pretty reluctant to enroll. So we're in the process of hiring someone new and hoping maybe that person will take a slightly different approach. In London, we have a peer navigator hired and working well. Actually, they've enrolled more than 3 participants now. Sorry, I forgot to update that. But they had big problems with getting the right kind of person hired. So of course, most street youth don't have much education. They don't have a resume or a curriculum vitae at all. Although they have strengths and skills and you know, personal assets, these things are often not valued by especially healthcare organizations in many settings. And so, you know, trying to find somebody who had experience as a homeless youth, was willing to do the job and ticked the boxes of the health unit that was hiring this person was very, very complicated. And in Montreal, we still haven't been able to hire anybody because I don't know if many of you know this, but HIV is actually criminalized in Canada. So if you, for example, are living with HIV and you do not disclose your HIV status to a lover or a partner or whatever, you can be sent to jail. If you are living with HIV, even if they know, your partner knows that you have it, but you're not virally suppressed and you transmit the virus, you will, you know, potentially go to jail. And so there's a huge amount of suspicion and, you know, and it's really hard to navigate some of these legal things, although through research, it's manageable. But from the community services side, you know, they don't fully trust that, for example, data wouldn't be subpoenaed or something. Because we do collect information on, you know, HIV status and use of antiretrovirals and viral load and so on. So just to wrap up, excuse me, there are a lot of evidence-based interventions that exist that can effectively engage street-involved children and youth if they're adequately adapted to the unique circumstances of the population. So one question, for example, is what will it take to get USAID PEPFAR to fund them at scale? And this actually isn't specific to street-involved children and youth, but you know, our peer support program, for example, in AMPATH has been pretty much defunded, even though peers represent like a hugely important opportunity to addressing HIV in adolescents and youth. Similarly, we spend a lot of time trying to figure out what are the optimal combination of strategies to engage high risk and hard to reach adolescent and youth populations, especially in low income settings, and especially when intersectional stigma is a major barrier to accessing healthcare services. And how do you build healthcare services in the absence of community services without overwhelming healthcare settings and providers? So in other words, because there's a lack of community services available, for example, in Eldoret, the healthcare setting, basically AMPATH, MTRH, is just about the only place for street youth to go to get help. And that is not really the mandate of healthcare services, right? But you can't just like deliver HIV testing in isolation from thinking about this person and the realities they're kind of living with. And so it's challenging. So I just want to really thank David Ayuku, Edith Pondy, Judy Washira for all of their support with this project, and all of our staff in Kenya, including our project coordinators and peer navigators, and of course the community and healthcare providers, both in Uasin Gishu and Trans Nzoia. Tunashukuru sana. And of course, CIHR, thank you for funding us. I'll be happy to take questions when we're done. Thank you.
Thank you, Paula. Very important, very unique. Also, we recognize the importance of youth that have not been well taken care of. We'll have questions at the end. We have two last presentations. I'd like to welcome Professor Ngure. This is on PrEP, HIV pre-exposure prophylaxis for adolescent girls and young women. Please take 15 minutes. Welcome, Kenneth.
Thank you, Professor Omaro. Greetings, everyone. I'll take the next few minutes to talk about HIV oral pre-exposure prophylaxis for adolescent girls and young women. And specifically, I will highlight three clinical studies that have been done in this sub-Saharan region to just show what we are learning around adolescence adherence. So I'm sure I'm preaching to the choir when I say that adolescent girls and young women are at high risk of HIV acquisition. In some places in sub-Saharan region, we are seeing up to 4 times increased risk compared to their male counterparts. And we now know that PrEP is highly efficacious and safe, but the key point is that it has to be taken. And this is a daily pill, so it has to be taken for it to work. There have been challenges, and this has been reported in many studies, including some from clinical trials to implementation science studies. Clinical trials on top of my head include FemPrep, which was also done in Kenya, Voice, and others, and also some implementation studies that some people in the audience have conducted, where we are seeing that adolescent girls and young women are struggling a lot with adherence. And then since oral PrEP is an additional tool to the HIV prevention toolbox, it's good to come up with ways to support adherence so that we can optimize PrEP as an additional HIV prevention tool. I'll start with one of the studies. This is known as the Umpire Study, which was conducted in both Thika and Kisumu. And the full name for the study was Monitoring Pre-Exposure Prophylaxis in Adult Women. The only part I will highlight about this study is the key point was around use of SMS reminders. At that point, and I still believe there's still a bit of equipoise on whether SMS reminders are effective in increasing adherence. I know there have been trials that have demonstrated that the use of SMS increases ALT adherence in 2 of them, but the third one did not. And I'm sure the others that have been done also showing some yes, some no. But by the time we are doing this study, when we started this study a few years ago, there was none that had been done around adolescent and young women. In the age for this cohort was 18 to 24. And also now we know there's also the age of social media, and none had been done around this time. So the key question was whether SMS reminders could increase oral adherence among adolescent girls and young women. So, and we enrolled a cohort of 350 randomized 1-to-1, and 9% of the participants in the intervention arm were able to switch. And but what we observed is that there was no effect of having daily SMS reminders to support adherence. But what we're also able to see, there was some delay in decrease of adherence over time. As you can see, the red bar is the SMS or the intervention arm, but these 2 arms were not statistically different. So what additional learnings from that study was that interest in PrEP was high. So there was high uptake, but the continuation and adherence was actually modest. And our study was one of the first to show detailed patterns of adherence that go beyond the initiation. And a minority of participants achieved PrEP adherence likely to be protective. However, there was a key observation within our study was low HIV adherence. And in the next study I'm going to describe, we're also able to see much lower adherence. And so the key question is, even when the intervention is not seen to work, is it that also the young women are taking PrEP during periods of risk, which is known as preventive effective adherence? In most of our clinical trials these days, we're also incorporating qualitative studies, and we are learning a lot, and that some of it complements and explains trial findings. And we were able to see that the high-risk perception was a key motivator for these adolescent girls and young women to initiate PrEP. And some of them were seeking peer approval and support before making decisions to initiate PrEP. And that's why part of our other studies that I'm not going to present today, we are also designing studies to work with peers to support PrEP initiation and adherence. A key learning point from the qualitative work is that risk perception is not static. During the 24 months of follow-up, risk perception changed based on individual women's changing life circumstances. For example, when they had high-risk partners, when their partners were not tested for HIV, when they were engaging in multiple partnership and that period stopped. In fact, this has actually been described as seasons of risk. And so even adolescents experience these seasons of risks. And the adolescents also told us that SMS reminders were quite helpful initially for habit forming, but much later they found the messages to be a burden to them. So probably SMSs could be effective early on when adolescent girls and young women are initiating PrEP. And the exit of this study, I also included this additional slide, is that we asked the women at exit, once we got our protocol approved, is to see what they would prefer for PrEP if other formulations were available. And just like in the field of contraception, it's not one size fits all for HIV prevention. So there's a significant proportion, actually a much higher proportion compared to others, is there are women who would prefer injectables. And even after experiencing oral PrEP for 2 years, only about a third would prefer oral pills. So as we are thinking about this and implants and vaginal rings, because we know that injectable cabotegravir is in the pipeline, implants, Istravil is actually in research, advanced research. So there are these methods. So there's need to accelerate development of these formulations so that young women, adolescent girls can have an option, can have a choice. And as we know, choice is empowering. And this was especially important because we heard from PrEP experienced adolescent girls and young women. So now I'm going to the next study, which is HPTN-OH2. This one used drug feedback to support adherence. And this was not done in our countries, it was done in Johannesburg and Cape Town, in South Africa and Harare in Zimbabwe. And this was based on what we have learned from the studies that have demonstrated low adherence. Qualitative studies have informed us that women were saying, why wait until the end of the year for you, or after 12 months, for you to tell us that we are not adhering? If we got this feedback much earlier, we would have been able to modify our behaviors in terms of adherence. And so this study had a standard adherence support, and there's a small typo there. The other one was a drug feedback report. So what would happen is that the young woman would get a feedback based on drug levels on whether they're adhering or not. On this study, again, like what we saw in Umpire, very high uptake, but there was no effect on drug feedback or by study arms at 6 months. But there's a few explanations. One of the explanations was that there was a challenge in operationalization of DBS feedback, meaning because most of these DBS studies, when you test drug, this usually doesn't come back immediately. So it may take a week, a month. So if you get these results a month later, they are unlikely to modify your behavior very well. And importantly is that we need to look out for effective adherence support feedback mechanisms that are point of care. And we are involved in a study where we're using a urine tenofovir test kit to see whether that would modify behavior better. And I know there are other studies that are also using point of care urine tenofovir tests. And we will see whether that is going to show different results. And we're also able to learn from this study that women who perceive themselves at risk were able to adhere to PrEP better. Again, as reported in Umpire, very low incidence compared to what would have been expected in the same cohort if there was they were not enrolled in a clinical trial research setting. And so again, the question there is whether the low incidence is based on preventive effective adherence, or are there other things that modify behavior? For example, like being canceled, being tested frequently, being in a cohort where they're receiving regular counseling, a regular clinical trial cohort. So those are some of the questions that will need to be answered in the future. Now, this is another study which I'm involved in, and this is known as the REACH study. The full title is Reversing the Epidemic in Africa with Choices in Prevention. And it's being conducted in Uganda, South Africa, and Zimbabwe. Actually came to an end just recently in October 2021, enrolling adolescents aged 16 to 21. But most importantly for this design is that adolescent girls and young women are allowed to experience both the ring or oral PrEP for 6 months. Then they close over to the product that they were not on. Then after 12 months of use, then they can choose the product that they would like after experiencing both products. And in terms of adherence support, is in this study we are offering a menu of adherence options. These include SMS reminders, like what was in Umpire, support groups, counseling, and even also the drug feedback, like what was in the HPTN 082. And adherence is calculated for the ring, vaginal ring, is usually calculated differently from oral PrEP. For rings, vaginal rings, it's calculated based on residue drug levels. And for oral PrEP is based on dried blood spots. What we're able to see among the adolescent girls and young women is that there was very high adherence, with non-adherence at all being reported by only 2.9%. This was very exciting results because I think, not because I'm involved in the study, but from what the studies that I know, I've not seen such high adherence in a cohort of adolescent girls and young women. And you can see even majority of them were adherent. I don't have time to describe the cohort better, but what I would only want to say is that there was at baseline, when we were enrolling, there was very high STI prevalence, about 35%, and many other characteristics indicative of HIV risk, including intimate partner violence, etc. So what we've learned is that it is possible to have very high adherence to biomedical prevention tools for adolescent girls and young women when adherence is tailored, the adherence support is tailored, as opposed to when you have one prescription of an adherence support, but when you give options so that the young women can choose to what fits within their lifestyles, it may be possible to achieve much better adherence. So I will stop there, and I hope I've been able to take much shorter time so that we will be able to leave more time for questions. And I would want to acknowledge all the investigators and funders involved in these studies. So thank you.
Thank you so much. Yes, indeed, you have really set them a very important topic. Now, a final presentation from Professor Kawango Agot's group, building capacity for youth in HIV research, the right 30 U30. And I think there's someone to make the introduction before Professor Kawango. Go ahead.
Sorry, I was muted. Hi, do I go ahead?
Yes, please proceed, Professor.
Okay, thanks everyone, and thanks for inviting me. This is Kawango Agot. I work with Impact Research based in Kisumu. And we requested to present, kind of change gears a little bit, requested to present on what we've done to build the capacity of young people in research. And we are going to share our experience that can also serve other people that are trying to do this. This is not the topic of the presentation, but this is the group that came together to actually work on this, and that is called RAY, which is reducing HIV among adolescents and youth. Sorry, reducing HIV among adolescents and youth. This is our logo with our slogan of "Nothing for us without us," and the co-conveners of RAY and also the people behind RAY is myself and Professor Bukusi of Cambridge. And hey, why is this moving to the next one? Ooh, okay. And so about Ray actually started way back in Cape Town when there was a conference, the first HIV conference, is HIVR conference, where young people were complaining about being invited to conferences and they are hardly able to understand even what's going on, even though lots of topics are about youth. And they were invited, yes, they said they appreciated being invited, they appreciated being paid for and being sponsored, but they said they floated almost throughout because the terminologies were so difficult, the sessions were so many that they didn't even know how to navigate. And that actually brought the idea of thinking about starting a conference, an international conference that would be focusing on young people. And so it was supposed to have taken place in 2020, but due to COVID restrictions was postponed to 2021. And 2021 is actually going to happen here in Kisumu, but 2021 Kisumu had the highest COVID in Kenya, and therefore we all had to postpone again to June 2022. So it's supposed to come up next year. And the conference provides a forum for adolescents and young people who are working on HIV advocacy, prevention, treatment, to submit abstracts and best practices for presentation at the conference. And some of the key features was that we expected that at least 80% of the presenters would be under 30 years, and that all presentations would be based on data from adolescents and young people aged 10 to 24. We were not going to accept any data from any person who's older, and that the conference language would be low enough for people to understand, especially those who are at high risk. And that doesn't mean that they are only those who have gone to school, maybe those who have minimal education will be able to understand. So it was going to be like and it's still going to be in really, really basic language. And one of the features that is the focus of this presentation is the 30 under 30 initiative. And so the premise of the 30 under 30 initiative is that adolescents and young people could be having ideas about some of the issues that are bothering us in terms of uptake of interventions, especially effective interventions, retaining them, and especially like what Professor Ngure just presented. They take it up, but they don't get retained, they're not adherent. And so we thought, the information is not just with us, senior researchers. The information can be with adolescents and young people, but they don't have the forum to express what they have. And least of all, they don't have a way to be able to even test out or pilot out those ideas that they may have. And so based on this, the RAY designed an initiative that's called 30 under 30, in which 30 adolescents and young people under 30 years of age who had promising ideas on how to address the burden of HIV among their peers would be provided with seed funding to pilot the ideas. And so we are going to walk you through how that process started and where we are currently. We sold this idea to the Bill and Melinda Gates Foundation, and they were really impressed with it. And so they agreed to cover the entire, it was $5,000 per person, $5,000 per awardee, to allow them to pilot their project so that we can see whether we'll be able to get some of the things that, address some of the things that have been bothering us. And so we formed a RAY Secretariat, initially of 2 staff, 2 ladies, and then we thought of the rule in Kenya of 1/3 the other gender, so we added 1 man, and these are the RAY Secretariat. We have Emmanuel Juma, we have Gerald Chieng, and we have Winnie Wadera. So in the spirit of nothing for us without us. Given that I'm not under 30, allow me to hand over to one of the Secretariat members, Winnie Wadera, to present, not just being 30 and 30, she's actually better than me in presentation. So Winnie, over to you. And just tell me next and I will advance the slide. Thank you.
Thank you so much, Dr. Kawango. So I'll proceed right ahead. The first thing we did was conduct a pre-conference workshop that brought together 152 adolescents and young people. This was to inform us on how to conduct the actual conference effectively. The conference was to be held in June 2020, just like Dr. Kawango has said, but because of the pandemic, we were not able to have it. So we are considering having a hybrid kind of conference where we'll have a few people attend in person and a few people will have to log on virtually. So being that we had enough time, we redirected our energy to mobilizing concepts from East and Southern African countries, especially under the 3 categories I'm going to mention next. HIV advocacy and community engagement, we have care and treatment, and then we have prevention. So we mobilized through various ways. We had newspapers, we mobilized through newspapers, we had Daily Nation, we had an advert running on Standard, we had the local media campaigns at 3 local radio stations, we had partnerships with Measure Leadership, which is a science and health focused outfit of media practitioners. We had partnerships with the LVCT Kenya. We had, we utilized social media, Facebook, Twitter, Instagram, all that. And then we had the one which we are most excited about was the essay competition that we organized in high schools through High School Principals Association. This attracted students under the age of 19. We targeted between the ages of 10 to 19. Next. Okay, so in the implementation of RAY 30 under 30, we also had a feeling that we needed to do something locally, and so we went around 5 counties: Kisumu, Migori, Siaya, Nairobi, and Homa Bay, to train on writing abstracts and concept proposals, and we did that with 113 adolescents and young people. So we wish to have done more, but we were financially constrained. Moving next. So in the phase 2, during the selection of the proposals, the second thing we did was to have young people recommend to form a planning committee, and we also for an international committee to just effect the process of of the protocols. So going back a bit from the multiple mobilizations, we got about 52, not about, we actually got 52 concept proposals and the essays plus 206 abstracts who we went ahead to link up with research writing experts to mentor them on how to package their ideas in a research format. Next. So when it came to phase 3, still during the mentorship process, this is where we did the most part. It has not, because still some of that process is ongoing right now, so it has not been an easy process having adolescents scientifically. It has been a rigorous process of back and forth, others dropping off. We have to find last minute replacements. And, I can say this is a promising space for young people, but young people require a lot of support, commitment, creativity, and patience. And so we're able to get, through our 2 co-conveners, Dr. Kawango and Professor Bukusi, we're able to identify 21 experts to mentor the 30 under 30 awardees to develop the concept essays into full protocols. And also the Secretariat coordinated with mentors to assist the adolescents and young people. It has really taken the whole village to enable this process to come to fruition. Moving on to the next slide, where we have, so finally we were able to constitute a team of 30 adolescents and young people who are on their way to becoming the next health researchers in the HIV world. We categorized their work basically in terms of 7 thematic areas according to how they submitted their work. We did not gag them on categories to submit. They submitted randomly, and so from the submission we're able to now make the category. So we have 7, and we are very excited about the ideas, but because of time, we just like to maybe read out some few. Starting with the first category on advocacy, we have a gentleman from Kenya under the under the advocacy category, of course, who wants to assess the effectiveness of using male champions in enhancing better menstruation hygiene management among adolescent girls in Mombasa County. And then we also have a young lady who wants to design a combo pack, which is a water bottle that has a pill pack and alarm clock package that a young person can own to assist in improving antiretroviral therapy. Still in that category of HIV testing, care, and treatment, we have Dina Akinyi. So is a young lady who wants to assess the effectiveness of using youth door-to-door health evangelism in enhancing uptake of HIV testing and linkage to care among adolescents and young people. Under the key and priority population category, we have a young lady who wants to assess acceptability and effectiveness of SMS intervention towards HIV risk reduction among transgender women in Kisauni sub-county in Mombasa. Then under the M-Health category, we have another young lady who wants to use a mobile phone app to increase uptake of information on HIV/AIDS and improve HIV testing among adolescents. And then on the last slide on the topics or on the themes, we have under the SGBV category, we have a unique group of 3 co-investigators who submitted one proposal, and they want to assess the effectiveness of a reporting network and SGBV information in reducing the incidence of sexual violence among adolescent girls and young women in their various counties. They're looking at Homa Bay, one is in Migori, and the other is in Kisii County, just to get the unique results influenced by the ethnic backgrounds. Then on the second last category here, under PrEP, we have 2 submissions that we think are unique for you to know. So we have a gentleman who wants to conduct an assessment of the effectiveness of male champions in addressing challenges associated with PrEP uptake, adherence, and retention among adolescent girls and young women in SEMA in Kenya. Then we have a lady who wants to focus on transitioning adolescent girls and young women on PrEP from community-sized dream safe spaces to government health facilities. Then lastly, here we have a different category on the structural category. We have a lady, so for her, she thought to develop a saving for a rainy day intervention towards reducing risky sexual behaviors and practices among female sex workers through increasing their financial security. So far we have had a number of submissions to the IRB, and as you can see on the screen, and some are still pending because we have challenges with young people, as I'm going to read in the next slide, that have barred us from being able to meet our deadlines, because young people really need a special and creative way to to work with them because of the urban mobility, their low concentration span, they're easily distracted. So sometimes the mentors didn't quite have it easy when it came to nailing them down to have the work done. So I've already begun introducing the challenges. So the next slide on challenges, I could cite a few. One being the outbreak of the coronavirus, which prevented the convening of the in-person RAY conference, which was to be held in June last year. And now we, like I said before, that we are thinking about working with a hybrid kind of conference, targeting a few in-person participants and a few participants participating virtually. And then we had some mentors not being able to commit to the mentorship process due to busier schedules by the day. We also had some mentees who gave up during the mentorship due to the rigorous writing process. And this far we have replaced about 14 adolescents and young people, and we've had to start afresh. We also faced challenges in regard to ability to not meet in person, or the inability to meet in person. And so most of the trainings, the mentorship had to occur virtually, and some were not able to, or were experiencing difficulties in joining Zoom calls because of the poor network coverages in their areas. And then another challenge was negotiating with international IRBs to waiver charges and expedite the process of reviewing the protocols. So in the process, we've learned a lot, and some of the lessons learned that we wish to cite here, for example, are peer administration of the award by 30 under 30 Secretariat, which understood the dynamics of young people, that is us. Efficiency of training through virtual platforms, they came so much in handy during this pandemic period. And we learned that also multi-sectoral mobilization skills through partner organizations, social media, mainstream media, learning institutions, because we went through high schools, college institutions, and word of mouth really was effective in reaching adolescents and young people. Then we also learned that essays were a really good tool to encourage young people to write, and we were able to work with the mentors to get the essays into a scientific document that can be presented to CERU and NACOSTI and so forth. And then we also learned that young people are really brain rich in terms of innovations from the wide range of topical issues they propose, and some of which I have read. And we also learned that senior researchers are willing to support adolescents and young people ventures into their complex field of research. We witnessed a lot of support from senior researchers and seasoned, researchers. And the work is not a walk in the park, but really the end of it is very rewarding. And we have some of steps that we consider are going to be like our next key areas of focus. And as it is really, we are asking ourselves, will the young people deliver quality work? Will they observe financial integrity? And those are some of the thoughts we are grappling with at the moment, because we're about to embark on the journey of implementation. For the entire year, we focused on writing. Now we are moving to implementation of the actual, pilot studies. And so we are just crossing our fingers that we are able to, do our best, even in that phase. So some of the areas of focus next are supporting the remaining 8 adolescents and young people to obtain ethic approvals and 10 to obtain NACOSTI approvals. We are looking at supporting adolescents and young people to complete their SOPs, work plans, and TORs. And we are also training our Ds on implementation science. This is a training that we're looking forward to happening in the second week of December. And we are blessed to have Professor Kinuthia and the team coming in to support. And we are also looking at training on startup, including how to use the SOPs in person and virtual, in terms of we are going to see who we can meet locally and have an in-person training, and the ones we cannot reach, for example, the ones who are coming from outside countries, we will have to train them virtually. We are also preparing simple Excel databases and training our Ds on how to enter their data, because that is going to be very key in terms of accuracy, and as we are looking forward to concluding implementation. Then we are also looking at implementing and monitoring the plot projects. We are very excited about it, finally seeing the ideas, get to the field and being tested and assessments happening and all that. We are really excited. And then the RAY conference. Amidst the challenges, we are still looking forward to conducting the RAY conference, where we are going to be presenting preliminary results. And then in the distant future, we are looking at having a conference that is going to bring all our Ds together and just share the results. We are going to bring stakeholders, partners, and just, for the young people to be able to present what they've been working on, what has worked, what has not worked, what were the challenges, and so on and so forth. And then we're also going to conduct data analysis and have publications made. So thank you so much for listening. I cannot end this presentation without, in our young people's language, giving shout outs, or professionally acknowledging some of the really key people that have supported this process, the youth, local and international planning committees for literally carrying this process on, the Bill and Melinda Gates Foundation, AHISA, Viv Healthcare, Kisumu County Government, LVCT Kenya, Lake Region Economic Bloc, and MESHA. Thank you so much for listening to our presentation, and God bless you.
Thank you so much. Now, we are done with the first session, the main session. Now we have the next part where we will have all our panelists. They're all in. We've had a very good afternoon, really. We've had introduction to KAHISA by Dr. Pondi. We've had introduction to implementation science by Dr. Masuko. We had Keegan tell us about teenage pregnancy, the multi-sectoral approach. And then we had Dr. Mugo with the transition among HIV-infected adolescents to adults. And then Paula with the street youth. We've heard from Professor Ngure on PrEP. And finally, Kawango and Winnie on Ray. and the capacity building. We have 2 questions. First of all, I'll have Romana, followed by Boniface. So Romana, you can go ahead. After that, we'll also have Margaret Muchai. Just ask your question, and then we'll keep taking questions. We'll take a series of questions for the panelists to answer. Romana, go ahead. Margaret, you can ask your question. Muchai. Okay, so we have lost Margaret. We'll have Romana. Are you able to ask your question now? Your hand is up. And Edna Okwaro as well. We also did have some questions which were raised in the question and answer, and one of the ones that I'd like to read out so that we get the benefit of the answer for everyone. This question is about teenage pregnancy, and it's from Vihiga County, from Kisa. This question is about this being a challenge, the big challenge on the uptake of family planning among the youth. It's discouraged by parents and relatives and peers, and said to lower libido. It's said to interfere with marriage. And so the question is, how can health providers deal with this? The next question, still from this is Kravin, is about HIV among adolescents, discordant couples. This would go to Kenneth. When one partner tests positive and the other no, there's a cycle of how will we stop the cycle of disease in motion? There's a lot of sensitization. The question is that there should be more sensitization on handling HIV within discordant couples. So this is Kenneth and Korir. Yes, let me read through the other questions, then we'll have the answer. I'll read through a few more if you don't mind. There was a question specifically to Dr. Masuko, somebody who's interested in the training. How do they go about getting this training? I think that's training in implementation science. And then to Edith on CAHISA, would CAHISA consider working with KEMRI as a technical advisor, given that some of the work going on in high burden countries, and that could be asked for other institutions as well. We can take those and as we wait for more questions. So those panelists can respond. Thank you.
I could jump in on the question of discordant couples.
Yes, please go ahead.
Yes, so I think the issue of HIV serodiscordant or serodifferent couples is a big question that could take a bit of time, but I want to highlight that it's good for couples to test together. Then once they're identified as serodiscordant, then it's good to put them on prevention. So the person who is HIV infected, it's good for them to go on ART. ART is actually, beyond helping the health of the HIV infected person, it's also a potent HIV prevention tool. Meaning that if one who is HIV infected achieves viral suppression, there is no chance of HIV transmission. So it's actually very good for them to go on ART. And before viral suppression, then the one who is HIV uninfected can go on PrEP. Probably I'll want to end that response there unless there are specific issues. I know there are usually questions of how discordance comes around and those kind of things, but we always want to summarize and say before HIV transmission, there's always a situation of a serodiscordant. One would have HIV and the one would be HIV uninfected. The duration of that serodiscordant relationship varies because of multiple reasons.
Thank you. Any career, please?
Thank you. Yeah, thank you very much. I think the question from Vihiga is what I wanted to emphasize is that it's really not an isolated case. The context that we live in, we still have a lot of myths and misconceptions, cultural biases and what have you. And so really the investment around education, particularly for the adolescents and young people, sensitization of the social environment, this is looking at the community, acceptability, of family planning, as it were. And also importantly, because just to say that I'm happy that Kenya, of course, the policy environment is pretty much supportive. So the other critical cog, of course, is really healthcare provider. Are we judgmental when administering some of these services? So that then if the healthcare system is supportive, that's now looking at the supply and the demand side now, looking at the user, the adolescent themselves are knowledgeable. And then the community itself is supportive. Then when you have those three critical issues, then of course the uptake and access is going to be enhanced. There was a very quick question looking at the correlation between FGM and teenage pregnancy. I believe there are a couple of studies which have been done in this regard, but even just looking at the general practice, some of the studies that we've done in places like Narok County, which is largely pastoralist and a lot of practices around FGM, is that FGM tends really to be a precursor for child marriage, and then of course that leads to teenage pregnancy. So there is a huge correlation around the same. So really the answer is yes. Thank you.
Thank you very much. Back to Professor Ngure, there's a question about peer for PrEP. And the question is whether will the peer be a positive or a negative? Who's qualified to appear? There's a specific question on that.
Thank you. I think peers can be either way. So if you are thinking about peers to support treatment adherence, then peers would be HIV-infected adolescent girls and young women. For our intervention, the one we are planning, peers would be HIV uninfected. And the intervention we are currently planning is to use HIV self-test kits as an entry point to PrEP initiation. So they will not be delivering actual PrEP, but we will train the peers to sort of deliver and support HIV self-testing for their peers, so that once they are negative and they know that they're interested in initiating PrEP, then they would initiate PrEP. And we will then have the standard arm and then this peer-supported arm to see whether you get higher uptake of PrEP in a peer-supported arm.
Thank you. Dr. Pondi, there was that question, maybe you could comment, and I would also add a question to Kahisa about this is really good potential to bring institutions together. So to what extent will Kahisa bring along the institutions and not operate beyond the individuals that are in Kahisa, which is a great innovation. Bring those great organizations that each do a lot of work, but somehow have not had the chance to work together. So Dr. Apondi, please.
Thank you, Professor Wamalwa. Let me have Dr. Inwani answer first. Dr. Inwani.
Thank you, Professor Malwa and Edith. Actually, the goal of Kahisa is not to have just individual members, but it brings together all the stakeholders who are involved in the care and treatment of adolescents or people in the space of adolescent health. And the goal is to involve the institutions, the government institutions, implementing partners, universities, hospitals, researchers, advocacy champions, as well as the adolescents. And we have heard that there is nothing for us without us. And therefore, the individuals were actually doing the preliminary work. And as Edith has said, that there is going to be an invitation for the membership. This is still an open invitation for those who are represented here. Yes, they are the individuals who will represent the institutions, but we also have the individual members who would drive the agenda for the institutions. So eventually, we would like to engage the institutions and have a sustainable Kenyan chapter where we might not continue getting support from our development partners. Thank you.
Thank you, Dr. Inwani. If I answer the second question on if we will engage KEMRI, and my answer is yes, we hope to engage KEMRI, and we already approached Professor Bukusi, and she gave us a positive feedback, but we do acknowledge their vast experience with the region that we will be doing the trainings next year, and definitely we hope to work with KEMRI. And then the other question was on elaborate on membership, but I think Dr. Irene has commented on that, that currently we are inviting individuals as well as organizations. And there was a question on eligibility for membership. As individuals, I think for as long as you have interest or work in the field of adolescent HIV, then we really would like to work with you. Thank you.
Thank you very much. There was a question to Dr. Mugo. I know you may have provided an answer about the use of soldiers in the cartoon booklet. And the question was about countries where, or settings where there's been war, recent experience of war, where the children might not take it very kindly about when they see this picture of soldiers. Maybe you could comment on that. And another question to Keegan, actually, to Corinne. This is about the, you said in your presentation that the situation of teenage pregnancies has not improved over many years. So what is it that has caused it not to improve? What is going to be different? With implementation science, do we know what to do, or we know but we can't do it? Thank you.
I think, yeah, very quickly, I had typed in this answer just to verbalize it. So use of soldiers as a representation of the immune system for people fighting HIV was something that we also thought about actually when thinking about it here. How will it be taken by the adolescents? They appreciate the meaning behind it. And the person who raised this question actually raised something very important. In war-torn countries, for example, and where there is rule, by uniformed men and women, this may not be the imagery that they would want. And so the work of implementation science is actually to identify what would resonate with that specific local population. You realize that with IS, you're very keen on the local person, the person who is receiving this intervention, rather than generalizability of it. So with the implementation outcomes, you're very keen on being very specific on the population you're targeting. Yeah.
Again, you're still with us?
Yes. Yes. So thank you for that question. And just to say is that I think when I look at the example of the countries which have been really able to change the tide, there's really a lot of push and coordinated effort under the leadership of the government of the day. And so we've not had really that push. I think most of the times we normally sit back, when exams are happening, that's where you see a lot of candidates, delivering a lot of public outcry recently during COVID. That national attention and drive under the stewardship of the government is going to be very critical. I talked about multi-sectoral response, and if you look at what we have currently, is that we have a lot of interventions by different actors. So we have a lot of interventions, but they really don't speak to each other. We have a lot of silos in terms of interventions, and when you don't have that collective, jointed effort towards this response, then it becomes a big challenge. So I think some of the reasons really is because of that really, the lack of, a deliberate national drive around this, and coupled by, all these siloed approaches, touch and go that we have, and really that will not give us the results that we need. And lastly, and just to speak to the whole issue around giving the adolescents that agency and ability to make the informed decisions is still one of the really big missing links. Sexuality education has really been a controversial issue in the country, and that is where some of these informed decisions can only be achieved. And so the parents struggle with this conversation. In school, it's really not at the desired level. So all these factors combine, and we have people, adolescents approaching, children approaching adolescents, and literally exiting that stage, if they're lucky to do so, without the tools and apparatus to navigate that tricky period of time. Thank you.
Thank you. There's more questions here. This one is a question to Dr. Kawango and Winnie. Is the support for writing papers and implementing the strategies on the course only limited to young people? That's for Dr. Kawango and Winnie. And the next question, when it comes to contraceptives, are children, that is below 18 years, allowed to access it? It's often hard to understand, as the Constitution of Kenya 2010 allows every Kenyan to attend the highest, yet this group under 18 are not able to consent. We'll get comments. This would be good to get comments from different people on this, including Dr. Inwani. And we have this is a comment in addition from Ruben Kiptui. In addition to uptake of family planning among youth, a social marketing strategy can be put in place to enhance behavioral change. Parents and youth can be targeted with different messaging family. That's a comment, so it's very welcome. Another comment, some parents really have difficulty in disclosing to their adolescents, even after giving them the tool of disclosure. How can we help to parent? I think Cyrus will take that one. So let's have that that group of questions. Dr. Kawango, Dr. Inwani, Dr. Mugo.
Okay, yes, the answer is yes. For this, those who are going to benefit will just be the 30, because they're going to base it on their pilot data, and also to see the process that started from the concept all the way to preparing the protocol, to submitting to CERU, to implementing, up to publication. So it's kind of a whole process that will be, we will have to see the end as publication. So unfortunately, yes, only for the 30.
Sorry, Dalton, I missed the question. Please repeat.
Okay, so this question is about accessing, and let me just read it as it is. When it comes to contraceptives, are children or persons under the age of 18 allowed to access? It's often hard to understand the Constitution of Kenya 2010, which allows every Kenyan to attain the highest, yet this group are not able to consent. I think this looking for a comment on contraceptive access by those below 18. And we can also have anybody else respond to that, apart from Dr. Inwani.
Okay, thank you for the question. The children below 18 are categorized differently. We have the emancipated minors, and therefore we would have to verify that the children below 18 are actually emancipated minor. In the guidelines for contraceptives, It is encouraged that those who present themselves and are below 18 for family planning, it is sort of like implied that they are actually sexually active, although we would like to verify that, and therefore they should not be denied family planning access. Professor Ndwati is here with me, she can correct me. So those who present themselves to the family planning services, we would have to do an evaluation, one for understanding, two, the risk factors, and help them navigate their risks and be able to offer safe services to these to those below 18 years. Prof, you could jump in, thanks.
Prof. Ndwati, are you able to unmute and make a comment on this? We'll catch up with Prof. So there was, when she does, we'll get her sense. Thank you, Dr. Inwani. And thank you, Dr. Kawango. I think, Saras, there was a question for you as well, right?
Yes, so
Yes.
Very quickly, parents not being able to disclose a big issue. And with the guidelines, we are being advised to push for joint disclosure. That is one where the health worker and the parent are involved, and it should start early. For the perinatally infected diagnosed in childhood, let it start at the age of 6 or 7 years. You do, take it very slowly until around the age of 12 when you fully disclose. Several studies have looked at the benefits of this dual disclosure, most of them qualitative, and many of them are showing some positive outcomes. Right now, we are looking at the attached data to see whether we can see some significant differences in outcomes, at least in satisfaction, when we have these different modes, parent alone, healthcare worker alone, dual disclosures. Yeah.
Thank you. We're starting to wrap up here, looking at the questions. I forgot one for Paula from the Umpire group. So you did mention briefly about law enforcement, but kindly if you can just elaborate that, because this is an area that law enforcement, you're likely to interact a lot with law enforcement. And also if you could comment on ethics, aspect of ethics. Many of us shy away from these populations, partly because of the ethical implications, studying them all. And you have that experience. Maybe you could share briefly what your experience has been with law enforcement. And law enforcement has a lot of facets to it, including people who would like to get them and remove them, and so they're not on the streets like has happened before. And of course, the fact that there's also the crime and criminal justice system. You could just respond to that.
Thank you for those very challenging questions. Yeah, law enforcement is a really important aspect of doing this work. So of course, street youth are often subject to street sweeps by police and county askaris, and they get, sort of summarily locked up and occasionally transported to, the nearest county boundary. Or what's happened here is they were taken literally to the Ugandan border in a lorry. And so, there's also a lot of challenges when they get, locked up, that, for those who are living with HIV, getting their antiretrovirals, if they're on PrEP, maintaining their PrEP, and or TB meds for that matter. And so actually the peer navigators have been able to build relationships with some of the police officers and some of the stations around to try and ensure that people who need medical care and medicines are able to get it. Which is not to say that it's easy, but there are good people everywhere. And that includes among the law enforcement officers of this country, and I think they ultimately want what's best. I think the problem is that sometimes they don't always know what that means, right? And have a lot of misconceptions, for example, about why children and youth are on the street. And, you know, they see the activities that street youth engage in out of the context of the circumstances of their lives. So the issue of ethics is, it's not as complicated as you might think. You know, for one thing, we don't experiment like with new interventions, okay, with street youth. With this population, we try really hard to focus on evidence-based interventions and how to implement it with this group. Now, of course, if they're 18 and above, they can consent for themselves and there's no problem. A lot of the women have children and they can consent for them. There are a lot of street families, right? So they can consent for the younger ones. But for the ones who are on the street pretty independently, we've argued consistently and successfully with our local ethics committees that you know, the guardians or parents cannot be counted on to have the best interests of these children at heart. So for the most part, what we do is we get consent signed by the county children's officer, sometimes for individual participants and sometimes for the project as a whole. And so that, because the county children's officer is essentially the de facto guardian of children on the street, and that's worked out pretty well. We also, you know, we try and do things in a way that's really about meeting their care needs first. Okay, so for example, with the Peer Navigator project, even though we've got a target population of 16 to 29 years, the peer navigators are absolutely encouraged and supported to engage with and refer children who are under 16 and adults who are over 29. Okay, and they do that in a way, well, in part to prevent participants from having to participate in the research to get the service. And we've been doing that now for 10 years and ultimately ended up starting essentially almost a primary care clinic really for street youth that incorporated some study enrollment into it, but it enabled participants, it enabled street youth to receive services without necessarily participating in the research, which is really, really important. So we've actually developed a whole lot of other processes and procedures, including like really extensive community engagement of opinion leaders in the community, engaging the barracks leaders of street youth, talking in barazas with, you know, with our target population about what's going on and what we want to do and how it's all going to work and so on. And Professor Ayuku, for example, has been working with this population in Eldoret for well over 20 years. And, you know, through the involvement of him and a social worker and some of the other key community stakeholders, you know, we've spent a lot of time building up trust between our research team and the street youth community. And then we also use tools that we developed, for example, a documentation of understanding and assent. So we don't just like, you know, go through the form with them and have them sign or fingerprint and witness if they're underage. But, you know, we try to make sure that they're actually really understanding what they're consenting or assenting to. So asking them questions that help us to have faith that they understand they're participating in research, they understand what's being asked of them, they understand the risks and the benefits, and they know that they can make a decision to not participate in the research without compromising their healthcare or other services that they might receive. And we've actually documented this in a paper that was published some years ago now that gives a lot of details. Maybe I'll add it into the Q&A chat thing so that folks can refer to that paper for more details. So hopefully that begins to answer your question a little bit, Prof.
Yes, indeed. Thank you very much. Really comprehensive answer. Really And there's one comment here before I hand over this meeting to Dr. Agnes. This is from Gaudensha, from the research on the challenge on PrEP adherence by adolescents after 6 months. I'm thinking if E-derived PrEP may work, especially after intensive health education and follow-up. Ken, you've seen that question. I don't know if you want to comment on that. You could comment on that as we wrap up. Ken Gure?
Yes, I'm trying to read it. I'm just seeing it now. So from research to challenges of adherence, 6 months of E-derived PrEP may work. I don't understand E-derived. I'm wondering whether you're saying delivery of, because my current work involves simplifying PrEP delivery. And some of the things that we are looking at is from pharmacy delivery, online delivery, like what is happening for other services. So we're exploring many other options. So I'm imagining E is electronically derived. So like where you have couriers working on like the online pharmacies. So we are going to partner with some of the online pharmacies to see whether we can deliver PrEP to people's homes with self-testing, etc. So I think I hope I got the question.
Thank you. Thank you. I'd like to thank all the panelists. I'd like to thank the audience, everybody who's asked questions, contributed. I think it's been a great afternoon. It's also been my pleasure to lead this session. I'd like to hand this back to Dr. Agnes, the host. Back to you.
Thank you very much, Prof. Wamala, for that wonderful session and for taking chair of that session and for just driving us through these conversations. We really appreciate. To our participants, thank you for staying with us till now and for contributing to this very important conversation around adolescent health. We really appreciate you. As we wrap up, we'd like to thank our panelists, our presenters, Dr. Masiuko, Dr. Inwani, Dr. Washira, Paula Brightstein, Dr. Cyrus Mugo, Kigen Korir, Dr. Pondi, Professor Ngure, Dr. Agot. Thank you very much for your presentations and for your insights. We've had a lot of comments saying that it's been informational, and we really do appreciate your time to give us those insights. To our partners who have enabled us to have this Zoom session, we really appreciate you. We have the UNFPA that has come through. We have CAHISA, and if you'd like to join CAHISA either as a partner or to do some work with CAHISA, they have given out their email address, admin@CAHISA. You can be able to get in touch and be part of this. We thank the Ministry of Health, NASCOP, University of Nairobi, who have always been our partner, and from Kenyatta National Hospital Research Department. We really appreciate all of you. So we'll bring this to a close right now. We do hope you have a wonderful evening. Thank you very much.
Thank you very much. Bye-bye.
Thank you. Bye.
Thank you.